Thank you, Mr. Chairman, and thank you, the audience and the organizing, for giving me an opportunity to present my studies to you. This was a very interesting concept that brought me to present this study. That the first thing was a question: what is true success in any surgical intervention? And as I was listening, I was also encouraged that since yesterday everybody speaks of individualizing the patient, that what might be success to me might not be success to somebody. So therefore we need to have a proper definition of success. And this started because our patients are very intelligent. I'm not sure in your part of country, but I believe all over. We call them that this is the Google generation. So when they come to you, they know something about their condition and what they expect. So these are the patients who even go on to influence the doctor what they must prescribe. As I mentioned to you yesterday that there's one of my slides that doesn't come. There's a slide that I wanted to show you that's showing that in our country we are sitting at almost 80% resistant to penicillin drug. So the strep pneumo, which is our commonest upper respiratory tract infection, if you give them low dose penicillin, you're wasting your time, because access to antibiotic is very free from the pharmacist. So that creates a lot of problem. But the patients, if they come and you don't give them antibiotics, you have not treated them. They'll go to another doctor. So that was the reason that I started to do this study. And we know that suppurative otitis media is a worldwide problem, mainly in the developing country. And of course the results becomes into a perforated drum which need to be repaired, and this was done early 1878 by Beth Holt. But tympanoplasty type 1, that's when you have to involve making sure that the ossicles are intact, eradicating the disease, and restoring the middle ear. But my problem was some of the patients, because of recurrent infection, you will give them a date, and when they come back for operation because of the problem of backlog, they come in and you find that the whole ear is wet. And then now the problem was, what do you do? In other words, you might not even operate them, because every time when they come, the ear drum will always be wet and discharging. And that's where this study was started. But in the literature, we know that the success ranges from some from 35% to 94% in children, and some 60 to 95% in adult. And the definition of success differ from surgeon to surgeon. Some surgeons, they consider different prognostic factors, but of significance is that some they evaluate them within 3 and 6 months. So this study mainly will be based on 6 months evaluation of a successful surgical outcome. We know the prognostic factors that has been identified that are well known, those pertaining to the patient, the age of the patient, and whether they have things like diabetic, or they smoke or they don't smoke, things like income status, and then on the perforation size, the site of the perforation, and whether it is wet or dry, and the status of the middle ear and the status of the opposite ear. Eustachian tube, everybody speaks about it, but it's one of the most difficult things to assess. I know now we do have a balloon, dilatation and so many things working on the Eustachian tube, but it's not easy when you do with the ear, in my experience. And then there's different techniques: onlay, underlay, sandwich, and of course there are different material, fascia, cartilage, perichondrium, or combination of the above. And anesthesia and approach, there are some people believe that you can do ear surgery under general anesthesia, many type 1 or myringoplasty, but all these patients for us has been done under GA. Approach: post-auricular and oral or transoral. and of course the surgeon and the experienced. We always think that the junior have a bad outcome, but maybe the senior one is a good outcome. It depends. We did one of the study where we found that even our seniors, they don't have good outcomes. But the objectives of the study was to evaluate the effect of different prognostic factors, and but of significance to define what is true global satisfaction success score in the ear surgery. I'm sure this can go to any other surgery that we do. We've just seen a very beautiful palatopharyngeal surgery, and we've seen a very nice cleft nose surgery. So you can individualize your patient to be able to have a global satisfaction success score. And then we are also proposing some satisfaction success score system, and also we wanted to compare that between the surgeon and the patient, what is success based on the indication of the operation, and also to define the surgical outcome. It was a combination of the prospective and chart review study, and all the patients who came for operation between 2005 and 2014 were included, and the data collection is a straightforward, the same one, evaluation of the patient, ENT examination, but of significance we're concentrating on the indication for tympanoplasty surgery, whether was it improving the hearing, eradication of the disease, restore of the perforated drum, the indication which was agreed between the patient and the surgeon, which we felt was important. And then, of course, there was a follow-up of the patient, meaning the drum status and all other indication which were agreed upon before operation were evaluated after 6 months. And it, of course, the SPSS statistical analysis was used. This was the form that we used to discuss with the patient, knowing the different indications that or different definition of success, that some believe that on evaluation at 6 months, if the drum is taken up irrespective of whether it's medialized or lateralized, that is a successful outcome. Or where there's increase in airborne gap of around 20 decibel in the conductive pathway, and increase in sensory neural hearing loss to at least within 15 decibel compared to before operation. Or maybe the middle ear erosion, that the middle ear space is normalized, and also the eradication of the disease. Maybe if the patient was complaining of pain, then the pain is gone. If the patient was complaining of discharge, and the discharge is gone. So based on those indications, then the score was set up for the drum, for the hearing improvement, stop discharge, and stop pain. It was the same for the surgeon. It was for the same for the patient, because we found that the satisfaction between the surgeon and the patient is not the same. You might do something on the patient and the patient is very happy, but you as a surgeon, you are not happy with your outcome. So therefore there is different understanding of what is a successful surgical outcome. You saw some beautiful nose. To the surgeon, they might say, look, I'm not happy with that scar, but the patient said, at least somebody has done something that my grandchildren are not scared of me anymore. So with that, we said, maybe there's a thin line between what is a successful outcome between a surgeon and a patient. We had 125 patients who were included in the study, and the age range was between 8 and 62, 55 male and 70 female, and the 61 was left-sided and 67 was right-sided. Even if we had 128 patients, we had 125, we had 128 procedures, because some were revision surgery and some were bilateral. Our surgical outcome success was 84%, which was within the acceptable literature of between 60 and 94%. and this was based on full take-up of the drum after 6 months. And then there were 16% of patients whom we failed to get a successful, either the drum perforation became a little bit small or they had reperforation. And all this was 19 patients which were reviewed at 6 months. And 116 was tympanoplasty, and the 12 were other surgical procedures. As I said, some were redo and some were bilateral. When we check the statistical accepted success factors, we found that etiology of the perforation had a 78% success rate if it's trauma, and infection it was 68%. And then however iatrogenic, let's say if it was from a perforated drum, grommet, so when you remove the grommets and repair the tympanic membrane, the success was very good. However, if the perforation was less than 50%, we had an 83% success rate, but a bigger perforation, as usual, had a low success outcome. And then the site of the perforation, the central perforation had a good outcome of around 95%. And the material, fascia in this study had a 73% success rate, and whereas cartilage and pericardium is a very good outcome. The fascia, pericardium and cartilage were done on the patient whom it was a redo, or the ear was wet, and it was a subtotal perforation. That's where we went for the thicker material. And then, but we found that the patient who had diabetes or HIV, they had a very poor outcome, which was expected. These were the patient who had granulation tissue, and then they have a continual graft falling off, and then they have reperforation and a lot of recurrent infection. So this was a very bad prognostic factor. And the age of the patient, less than 10 years of age, in our studies, even if there are not so many, but the drum pick up well. There are some people who feel that you cannot do ear surgery when the patient is still less than 10 years of age. But for us, we felt that it depends. And also the very old patient, greater than 60 years. This was one of the ladies that I really struggled. I might have taken her to theater maybe 2 to 3 times because we were not succeeding in getting the drum to pick up. Every time we do, it was always reperforating, and it was an anterior perforation also. And then the technique, the onlay, the underlay, in my hand, the sandwich was very good. They had at least 85%. The smokers also has a very poor outcome, but the non-smoker had a good outcome. And all these other factors, they were not statistically different. The dry or the wet canal did not make any difference. The middle ear mucosa status, whether it was normal or infected, did not make difference. Status of the contralateral ear, income status, the antral drainage. When I was trained, every year you were expected to do an antral drainage and make sure that the additus antrum is a little bit open and is communicating with the middle ear. But in this study, even those that we did and those that we did not do, there was no difference really. The site, left or right, for right-handed surgeon and left-handed surgeon, it did not make any difference. Some literature said, if you are right-handed, it's better to do the left side, but in ours it did not make difference. And oral approach or transcanal or post-auricular, there was no different. Gender was also the same. Eustachian tube and anesthesia and surgeon, it was difficult, as I mentioned earlier, because it was not tested and anesthesia was the same and the surgeon was the same, so we could not measure the difference. On discussion based on the literature review, there's a lot of controversy. There's no agreement in the opinion on most of these things. The same age, mixed opinion, size and site of the perforation, except that size, most literature agree that the smaller the perforation, the better the outcome, but the bigger perforation is a poor outcome. But most of the opinion are mixed. I'm not sure what is your experience, but the status, wet and dry, it did not make much difference. in some, but mainly it's mixed opinion. Status of the contralateral mixed opinion. Graft material, there were those who felt that if you use temporalis fascia, it has a worse outcome than cartilage and perichondrium. And also the income, those who have a good income has a better outcome than those who have a poor income, which is just depending on the patients where they come from. And then the technique, onlay, it was said to be better than underlay, and local anesthesia was worse than GA, which really makes sense because I'm sure the patient won't be stable. And post and retroauricular, they say post and retroauricular was better than end oral, some studies. And eustatin tube, as I mentioned, difficult to assess. Smoking, smoking because of the affectation of vascularity also has had a poor outcome in some of the studies that were done, and they always felt that maybe a senior surgeon has a better outcome. With the surgical outcome and patient satisfaction, we decided to ask the surgeon and the patient that, and it was categorized between very satisfied, satisfied, and not satisfied. It was interesting to note that very satisfied patient in the operation that was done and surgeon, they correlate in 94%. But if you remember, the surgical outcome was 84%, but the satisfaction rate was 94%. Whereas satisfied with the outcome surgery, it was 83%, which was in keeping with the surgical outcome earlier of just general drum take-up in the study. But the surgeon was not satisfied. So I thought maybe the surgeon was very, very critical to himself, that even when the patient, they are happy that at least somebody has done something, maybe the hearing is a little bit better or the discharge has improved a bit, the patient was still satisfied, but the surgeon was not happy. In the not satisfied, it was the same, that the surgeon was not satisfied at all, but the patients, very few of them were not satisfied. Therefore, with the study, we came to the conclusion that there's a strong correlation between very satisfied surgeon and patient, and at the same time that the satisfied success score is 83%, which also correlate with the surgical outcome of 84%. So therefore, the true global success is a combination of surgical outcome and patient outcome, which increase your satisfaction rate to almost 94% from 84%. So therefore, patients need to be individualized based on the indication on what a surgeon want to do. This was also echoed by the issue of the tinnitus, that you can't say you're going to eradicate tinnitus. You might say, I might be able to improve. So maybe for the patient, you might say, look, I think I'm going to stop the pain, or I'm going to improve the hearing, or I'm going to create for you a safe ear. With that agreement between surgical outcome and agreement of the patient, then you can come with the final true success rate. Because there's no agreement on what is true success of the ear surgery or tympanoplasty in the literature. Thank you.
Thank you very much, Dr. Tshifularo. Usually outcomes research is pretty interesting because it gives us like a feedback, and it is something we should always strive to do as clinicians. Well done for the excellent job. Would you entertain comments, questions? The hall is depleting at a very rapid rate, so let's see how we step up things so that we can also disappear from here. Sir?
In the surgical outcomes, I came in sort of halfway through your presentation, so I missed the first half. Yeah. But in the surgical outcomes, did you look at hearing at all, or change in hearing by audiometry?
Yes, I said that in literature they speak of improving hearing to within 15 dB or increasing airborne gap to around 20 dB. So there are those, but most of the studies that we found, they don't consider the patient's experience and satisfaction. It's only the surgeon. So that's why the title is a global satisfaction success score, because now he's basing the surgeon and the patient agreeing on the outcome.